This video illustrates an autologous cranioplasty after a decompressive hemicraniectomy. After being placed under general endotracheal anesthesia, the patient is positioned supine on the operating room table with his or head turned to allow full exposure of the previous hemicraniectomy incision, which is then prepped and draped in sterile fashion. An incision is made along the previous hemicraniectomy incision through the galea down to the skull. Scalp hemostasis is achieved using a combination of electrocautery and application of Raney clips. The incision is carried along its length, again exposing the underlying skull while avoiding damaging the brain parenchyma. The scalp is then reflected, with care taken to separate the galea from the underlying dura. The temporalis muscle must also be reflected, either together with or independently of the scalp flap, to ensure an optimal cosmetic result. Once the scalp and temporalis muscle have been reflected entirely, and the bone edges have been completely identified, exposed, and denuded of soft tissue, the autologous bone flap should be brought into the operating field for attempted replacement. Occasionally, the bone flap cannot be safely replaced without further relaxation of the brain. This can be accomplished via cerebrospinal fluid drainage using a brain cannula. Once sufficient brain relaxation occurs, hemostasis is achieved, the bone flap is replaced over the cranial defect, and affixed to the skull. The scalp flap is then replaced over the skull, and the temporalis muscle and galea are reapproximated with 2O vicryl stitches. The skin is then closed with either staples or suture. Prior to closure, a subgaleal hemovac drain may be placed to prevent fluid accumulation and postoperative facial swelling.